Hello everyone. Now I'll be discussing question of neurology. So we have a 34-year-old gentleman. He has difficulty in swallowing and blurring of vision. He also have mild shortness of breath and he returned to home after 7-day Caribbean trip where he snorkeled, ate locally cured fish, hiked in a forest. Well, temperature is normal, BP is normal. His oral mucosa is dry, speech is slurred, pupils are dilated, and reacts sluggish. Neck muscles are weak, difficulty holding his head, muscle strength 1 by 5 in the upper limb, 5 by 5 in the lower limb. And what the next best step in the management of this patient? Well, the best answer of this is equine antitoxin therapy. But we should know what the diagnosis. Most likely he has foodborne botulism. Is a potentially life-threatening condition. It is caused by injection of food contaminated with botulism toxin. Well, how this toxin comes? By germination of Clostridium botulism spores. And classically they germinate in the canned food. So improperly canned food, cured fish provide appropriate environment for spore germination, and ingestion result in absorption of a preformed toxin. Toxin is preformed. Now come the question. We have seen the patient, he has neck weakness, dilatation of the pupil, okay, and even upper limb weakness is there. And we just learned it is due to all preformed toxin. Now stop the video, write down the answer. I have a question for you. What is the mechanism of action of this preformed toxin? It inhibits presynaptic acetylcholine release at the neuromuscular junction. So that's why it's going to cause muscle weakness. I have one more question for you. This symptom develop after how much time? And I have one more question for you. This is the botulism has preformed toxin. Tell me any bacterial infection which also has preformed toxin. So bacterial food poisoning, to be more precise, which has due to preformed toxin. So we have two questions at the moment. Stop the video, write down the answer in your copy. Well, as far as bacterial preformed toxin causing food poisoning is Staphylococcus. Food poisoning. And as far as at what time it develops in within 36 hours. It's a preformed toxin. Prodromal symptoms include GI discomfort, dry mouth, and sore throat. Like in this case also, patient has dry mouth and sore throat are the prodromal feature that we are getting in this patient. Well, ultimately, patient bilaterally cranial nerve palsies can develop, which can lead to dilated pupil, blurred vision due to fixed pupillary dilatation, diplopia, dysarthria, dysphagia. They are the 4 Ds. Famous Ds: dilated pupil, diplopia, dysarthria, and dysphagia. These are the classical 4 Ds. Facial weakness can be there. But the classical hallmark is descending weakness. It's such an important point. We have one more entity like GBS syndrome, Guillain-Barré syndrome, where it is a type of ascending paralysis. So descending paralysis is a classical feature that we see in a patient of botulism toxicity. That's why neck is weak and upper limbs are weak. Respiratory failure can occur if there is diaphragmatic paralysis occur. Well, diaphragm is the one organ which is almost in the middle of the body. So whether it is botulism where we have descending paralysis or Guillain-Barré syndrome where we have ascending paralysis, diaphragm is in the middle. Both can involve, both type of problem can involve diaphragm, which can lead to respiratory failure. Okay. Well, so if you are suspecting any patient with botulism food poisoning, check the toxin in the blood. You take a blood sample, check for toxin, supportive care, and you may give host-derived antitoxin we can give to neutralize the toxin which is there in the blood. Well, let's look into other option, Atropinepyridoxine. They are used in organophosphorus poisoning, having feature of cholinergic excess, bradycardia, myosis, bronchospasm, vomiting, diarrhea. If you can see, it is almost a reverse of what the feature we got it. Okay, there was a mydriasis, people were dilated. Here we are getting meiosis. Okay, because it's all because of cholinergic toxicities there. Now, when we use atropine, they block the peripheral effect of acetylcholine at the muscarinic receptor, and pyridoxine aid in reactivation of acetylcholinesterase, which is going to generate more and more acetylcholine at the neuromuscular junction. EDO Forming Tests, the short-acting acetylcholinesterase inhibitor, it improves muscle strength, weakness in a patient of myasthenia gravis. Okay, and that helps in making a diagnosis that we are dealing with a case of myasthenia gravis. Now, myasthenia gravis, we are well aware, it happens in female and male. Now the question is, in male myasthenia gravis, at what age it occurs? Stop the video, write down the answer. In male, it is 6th to 8th decade. In female, it is in 20 to 40 years. But in males, it is 6 to 8 decade. Okay, and they are fluctuating and fatigue, weakness of the ocular movement also. Symptoms are worsen in the evening fatigue. It's a classical feature of any myasthenia gravis. But the more important is that it is 6 to 8 decade. Well, one more question for you. Question is, which malignancy is associated with, very often associated with myasthenia gravis? Stop the video, write down the answer. Thymoma. Every patient of myasthenia gravis should be investigated for thymoma. Option D, intravenous methylprednisolone. That's another treatment of botulism. This we especially give in conditions like multiple sclerosis, which can also have muscle weakness. Okay, and this is more in female around 15 to 50 year, and patient classically has optic neuritis, internuclear ophthalmoplegia, and transverse myelitis. They are the important clinical feature that can happen in a patient of multiple sclerosis, and the problem is disseminated in time and space. Finally, skin examination for attached ticks. Tick paralysis can cause neurotoxin, and neurotoxin by tick can lead to muscle paralysis in the saliva. What are the clinical features of this neurotoxin? What it can do? It can lead to classically paresthesias, fatigue, followed by ascending muscle weakness. But how will you differentiate it from Guillain-Barré syndrome? Stop the video, write down the answer. Again, Guillain-Barré also, we have an ascending type of paralysis. Here also we have an ascending type of paralysis. But how will you differentiate? Stop the video, write down the answer. In this, it is usually unilateral. In Guillain-Barré, it is bilateral. Okay, and even if bilateral is there, they usually have not the same type of weakness. One leg may have more weakness, other may have less. So in such cases, you have to search for the ticks and once you remove it, recovery is very fast. Recovery is almost within 24 hours patient recover, and moreover in Guillain-Barré syndrome there may be history of diarrhea in the past, and there is no such history in tick paralysis. But asymmetrical is the one point, because Guillain-Barré syndrome is never unilateral, it's always bilateral. Otherwise clinically it resembles like the tick paralysis resemble like Guillain-Barré syndrome. Golden line to remember: tick-borne botulism is a potential life-threatening condition because it can involve foodborne botulism is a potentially life-threatening because it can involve the diaphragm, caused by injection of food, improperly canned food, contaminated with botulinum toxin. Symptom typically occur within 36 hours of ingestion, and bilateral cranial neuropathy followed by symmetrical descending type of muscle weakness is there. Thank you very much.